Let's just get right to it because this is a huge one. Most students miss respiratory questions because they're stuck on memorizing facts, when the NCLEX is really testing if you can interpret what's happening. If you've ever felt that frustration, you know exactly what I'm talking about. And then there are ABGs. So many people get tangled up trying to solve them like some kind of complicated math problem. But you've got to shift your thinking. These aren't just numbers. They're vital signs. They're literally your patient's body screaming at you, telling you how close to a disaster they really are.
And that right there, that's the whole game. The NCLEX doesn't really care if you can spot something on a chest x-ray. What it really wants to know is, okay, you saw it. What are you going to do about it? What is your absolute first priority? So today, we're going to give you a little preview of how we at Exam Coaches train you to think through these respiratory cases exactly the way the board expects you to.
We actually have a name for this. We call it the respiratory reasoning gap. It's that tricky space between knowing a piece of information and actually being able to apply it under pressure to make a safe call. Let's break down where good students, smart students like you, tend to fall into this gap. Here's the thing. The NCLEX almost never tests these things by themselves. It weaves them all together into one complex scenario. It's testing if you can connect a weird lab value to what you need to do after a procedure, or if you can link a red flag symptom to the right immediate action. Just memorizing a list of facts isn't going to cut it. You need a framework. And that's exactly what we help you build, a solid framework that helps you turn all that raw data into a confident clinical decision. So let's do a quick fire run through of how we apply this kind of thinking to some of the most common respiratory diagnostics you'll see. First up, the chest x-ray. Look, the test isn't about you becoming a radiologist. Inside Exam Coaches, we teach you a system. You scan it with purpose, using a structured airway breathing circulation pattern. Why? So you spot the things that can kill your patient first. So boom, you see this on your screen during the exam. Tracheal deviation. Your brain shouldn't just think tension pneumothorax. It needs to immediately fire up a priority filter. What system is about to fail? What is the single most important thing I have to do right now? That's the kind of reasoning we train. All right, let's switch gears to sputum analysis. Now, this seems simple, right? But the NCLEX loves to get into the nitty-gritty of procedures like this, because all those little details are really about patient safety and getting an accurate sample. So they'll hit you with a question just like this. Why, first thing in the morning? The answer isn't just because it's the rule. The real nursing logic connects pathophysiology, how secretions pool overnight, to the principles of microbiology. We teach you how to see and explain those connections. Now, for procedures like a laryngoscopy or a bronchoscopy, the word you gotta have flashing in your head is invasive. Anytime we're putting a scope down into a patient's airway, we are introducing a ton of risk, and the NCLEX absolutely expects you to be able to anticipate and monitor for those specific risks. This is a perfect example of where your clinical judgment has to shine. A little bit of bloody sputum after a scope? Probably okay, just some irritation. A lot? That's a huge red flag. So how do you tell the difference? Well, it comes down to a systematic process. You're assessing the amount, you're watching for trends, and you're keeping a hawk eye on their vitals. It's a system, not a guess. Now look at this. This patient is positioned for a thoracentesis, and they're not just leaning over that bedside table for comfort. This specific posture is all about safety. It actually spreads the ribs apart, making it easier and safer to get into that pleural space without, poking a lung. Every single detail like this has a why behind it. And here it is, the classic post-procedure nightmare question. Your patient suddenly can't breathe. That just screams pneumothorax. So what do you do first? You don't just run to call the doctor. No, your first action is always assessment. Our framework walks you through it. Assess breath sounds, get some oxygen on them. You act first, then you notify. Pulmonary function tests. These can feel so overwhelming with all the different numbers and weird abbreviations. But we teach you how to cut right through all that noise and focus on one simple thing, recognizing the pattern. Honestly, it often boils down to this one key value, FEV1. Just remember this. With obstructive disease, you can't get the air out. With restrictive disease, you can't get enough air in. We show you how the pattern in that one single value can point you to the right answer super fast. Okay, let's talk about the TB skin test. Doing the injection is the easy part. It's the interpretation where so many students get tripped up.
because it's not a simple positive or negative thing.
So is 12 millimeters a positive test? The correct nursing answer is it depends, right? It totally depends on the patient's own risk factors. That 12 millimeter result means something completely different for a nurse than it does for a patient who is immunocompromised. We train you to use that whole clinical picture and to remember that a positive skin test is never the final answer. It's just the trigger for the next diagnostic step, like getting a chest x-ray. And here we are, ABGs. We take all the fear out of them with this super simple, repeatable 4-step method. No complicated calculations, just a clear, logical flow. First, you look at the pH. Is it acidosis or alkalosis? Simple. Then you look at the PaCO2 and the HCO3 to figure out if the problem is respiratory or metabolic.
Let's just try it real quick. With a pH of 7.30, you know instantly from step 1 that you are dealing with acidosis. Easy. Next, you'd look at that CO2. It's 55, which is high. Does a high CO2 cause acidosis? Yes. That's step 2. You see? The framework turns a jumble of numbers into a clear story.
The D-dimer test. This one is so critical because when you hear D-dimer, your brain needs to immediately think of one of the scariest respiratory emergencies out there, a pulmonary embolism. But it's a screening tool, and it gets misinterpreted all the time.
Now here's a scenario that demands real-world judgment. Your patient's D-dimer comes back high, which is scary, but the patient looks totally fine. You don't just hit the big red panic button. The framework tells you to take that lab value, combine it with your full clinical assessment, and start anticipating the next logical step, which is probably going to be a CT scan.
And this really brings us to the most important point of all, integration. All these different tests we just flew through, they aren't just separate topics you cram into your brain for an exam. It's really about building one single powerful way of thinking. It's about using all these tools together to recognize when a patient is getting unstable, to see the patterns in all the data, to always protect the airway, and to act confidently before your patient goes downhill.
So, at the end of the day, Exam Coaches isn't about just throwing more respiratory content at you to memorize. We train you in the skills that actually count, on the test and at the bedside. We train interpretation, so you can see the real story happening behind the lab values. We train prioritization, so you always know what to do first. And we train true clinical judgment, so you can make those safe, life-saving decisions when the pressure is on. That is how you crush the NCLEX, and that's how you become the nurse you're meant to be.